artificial intelligence is at the core of our advances in genomic medicine. And as you can imagine, just the sheer amount of data that's generated now per patient. Let me just give you a sense of scale. At Caris, we sequence about 600 patients per day, whole exome and transcriptome. Over 1 million data points per patient. This whole exome transcriptome is married with imaging data from their pathology H&E. It's also married with clinical outcomes data as well. So particularly what treatments they've been on, how long they've been on those treatments, their overall survival. And in totality, it's generating over a petabyte of data per month. I mean, so it's just a substantial amount. No human mind can conceive or think about or determine what are all the patterns that can be potentially found within that massive amount of data. So we need obviously powerful tools and powerful computing. And what you've seen in very recent years is really the convergence of powerful sequencing technology, powerful computation, and then the implementation of powerful algorithms coming together to really advance our ability to dissect this data at a scale and in a capability we've never been able to do before. So a couple examples I think are important. So one AI algorithm that we deploy in every case is an algorithm we call GPS AI. And what this does is determine the tissue of origin of the cancer based off the whole exome and transcriptome. So not based off the pathology report, not based off H&E, just based off the genomic data. And it was originally designed for cancers of unknown primary, so cancers where we didn't know the origin. But what we ended up finding out is we put it into production, it ended up being not just useful for cancers of unknown primary, but also really useful for identifying misdiagnosed cases. So every day we get a handful of cases where the computer algorithm says it's a different diagnosis than what came in on the pathway. And so what our pathologists will do is they'll take that case, they'll work it up further with some additional IHC stains, they'll contact the ordering physician to walk through the case. And again, on a daily basis, we overturn diagnoses. And this is really important because the cancer care journey and the path and the road that a patient is going to take, all is based, the first most fundamental thing is based on the diagnosis. It determines the chemotherapy regimens, determines the therapy regimens, determines the entire course. And so obviously vitally important to have that. We're under active development of numerous other AI algorithms. We're presenting here at ASCO an AI algorithm, this work led by my colleague, Dr. Jim Abraham. It's an AI algorithm focused on predicting whether a patient will develop brain metastases. So as we know, brain metastases is unfortunately a very lethal avenue for how cancers metastasize and cause unfortunate death of patients. What we know is that in certain cancers, there's some novel targeted agents that can be used to that work better against brain metastases and potentially can prevent brain metastases from happening. There's also some additional clinical trials being done looking at brain met prophylaxis as well. So very excited by this work. We really are looking to partner with academic colleagues looking at prospective clinical trials that harness this data, knowing whether a patient will be at high risk of developing a brain met and trying to prevent those brain metastases from happening. Also, additional signatures and therapeutic prediction like immunotherapy, platinums. We have also one for chemotherapy, specifically in metastatic ER-positive disease and others. But I think the high-level story here is by leveraging this huge amount of data, these clinical outcomes, and these AI algorithms, we can develop new tools that are very helpful for physicians in guiding the course for their patients.